Thank you very much, Dr. Abdelmajid, for the introduction. And I would like to thank the Emirates Cardiac Society for the invitation to be part of this magnificent conference. Before we talk about how we manage, we need to talk about the impact of bleeding after coronary stenting. Everybody say, well, my patient bled, well, I gave him a couple of units of blood and that's it. But this is not the right way. You remember when we have a patient bleeding, he developed hypotension, we have to stop a lot of his medication, especially the antiplatelet medication, and that may lead to ischemia, and stopping the medication may lead to stent thrombosis, and also transfusing the patient, give the patient a kind of blood which lacks nitric oxide and may induce inflammation, and all of that may contribute to stent thrombosis and may lead to mortality. So bleeding is not a safe thing to happen. And just let me go almost 20 years ago at the time of the acuity study, and just if you see that, is this our laser pointer? Yeah. So if you have an MI after intervention, so in the first day after the intervention, there is high risk of mortality, increased risk. But this really comes down and get less risky within 1 month. However, if you bleed within the first day, there is a risk of mortality, which is really high, more than 5-fold, and thus continue. The risk of mortality after bleeding may continue for a few months after the bleeding. And transfusion do the same thing. So again, bleeding is not a simple thing. And this is also a risk study from ADAPT-DEST study showing that post-discharge bleeding, that we already sent the patient home and he developed bleeding, there is almost 4-fold increase of the risk of death if you develop bleeding when you go home. So, this is again from Vergimigli from Italy, comparing whether you have an MI or to bleed. If there is minor bleeding, BARC2, yeah, that's reasonable, and the risk of MI for mortality is much higher. But however, when you go to BARC3, and especially BARC3C, it's the risk exceed the risk of death from myocardial infarction. So this is, we have to agree that bleeding is not a simple thing and is not a benign thing. Now, who are the patients at risk for bleeding? Everybody knows there are some predictable bleeding risks, like prior bleeding surgery and stacking of anticoagulation. And let's talk about stacking of anticoagulation. Look at that. We give the patient heparin during the procedure, post-PCI. Some people give post-PCI no molecular weight. Some people give 2B3 inhibitor. Some people decide to switch from unfractionated to bivalirudin, and some changing between the P2Y12 inhibitor and changing the dose of aspirin, say, well, I prefer to give higher dose. All of that stacking may increase the risk of bleeding. There are unpredictable bleeding risks like trauma, subclinical pathology, undiagnosed cancer, a new onset atrial fibrillation, and something that we don't predict, that some patients may be hyper-responsive to that. Okay, so this is the bleeding risk, and a lot of things related to comorbidity. Everybody knows about renal and liver disease and active cancer. Old age is a risk factor. Anemia to start with and elevated white blood count is another thing. Bleeding history in the past. And iatrogenic thing, especially for giving anticoagulation, whether oral anticoagulant or non-steroidal or surgery, all of that increase the risk of bleeding. But we have to add things that probably we are not aware of. Remember, female gender is a risk factor for mortality and bleeding. The other thing is the peripheral artery disease and abnormal body mass index. The abnormal body mass index is is similar to inflammation, and inflammation may increase the risk of bleeding. Now, if we distribute all of those risk factors to the research body, we see almost more than 40% of our patients are really at high risk of bleeding. So now we know that the risk of bleeding is high, so how can we treat that? And everybody say, well, my patient is at risk of bleeding, so I'll give shorter DAPT, and the best way to give him a bare metal stent, and because we'll give dual antiplatelet for just a month. But there are two studies that everybody knows about, the LEADER 2 and the senior, comparing the bare metal stent with drug-eluting stent in the senior, and here a drug-coated stent, that's polymer-free. And look at that, there is significant improvement in mortality, MI, stroke, ischemia, and ischemia-driven revascularization when we compare drug-eluting stent to bare metal stent. So bare metal stent is out, even for the elderly patient, because we get better result and better improvement in all this ischemic event. So that's about it. Now there are other trials. I'm not going to go through the details, but just everybody read about the master. The science will discuss that. This is the Onyx one. Also will discuss the Evolve with the Synergy stent. But what we have, look at each study. There are different explanations for the high-risk patient. This is for the LEADER, this is for the ZAS trial, this is for the Science, this is for the Evolve, this is for the Onyx, so this is for the Master DAPT. It's all of them different. So we have unmet need for standardization of the definition of the high-risk bleeding. So, well, okay, no standardization. Let's talk about risk score. And everybody knows about the DAPT score, but we are using the DAPT score to give the patient the opportunity to give prolonged period of DAPT treatment. And there are too many risk score. I did, when I was invited, I received the invitation for this lecture, I did call Roxana Mehran, and I asked her how many risk score, and she said, I can't remember them. It's more than 27. But let's talk about some of them. Everybody of this risk score have different definition for the bleeding. So someone used the Gusto, someone used the BARC, someone used the TIMI definition, and the validation is different. So I don't think we can depend also on the risk score to assess our patient, because this is what we get from the randomized control study. This is we get a combination of all of those patients, whether they are low risk, intermediate risk, and high risk. And then we come with the risk score for the average patient. But there is really no average patient in real life. There are no average patients. So we need to find better definition. And that's the ARC, the Academic Research Consortium, came together in 2 meetings and really reviewed all the study and reviewed all the risk score and the high bleeding criteria, and they came with this. This is the high bleeding risk consortium that gave major risk factor and minor risk factor, or major criteria and minor criteria, and to say that if the patient will be considered high bleeding risk if there is at least 1 major and 2 minor criteria. This is the measure. I'm not going to go through them. It's available. You can download the application and put it on your mobile and you can calculate that. But just remember the chronic liver disease and the advanced kidney disease and the chronic bleeding diastasis and the malignancy. Nowadays, because our patient getting elder and we at the advancement of the cardiac treatment, a lot of our patient getting cancer and we are not aware of them. The minor things you know about them, that's the age and the low hematocrit. So with that, we came to the high bleeding risk, and this is the high bleeding risk definition, And with that, we can review all the guidelines, whether on two sides of the Atlantic, whether in Europe or in the USA. If there is no high bleeding risk, we can continue 6 months or longer. If there is high bleeding risk, we give 1 to 3. If the patient is acute coronary syndrome, everybody say if there is no high bleeding risk, 12 months, a high bleeding risk, 6 months. This is in general. But can we confirm that this is what we call, and the summary of what I talked. But if we review now what's going on with those trials, did those trials cover all the high bleeding risk criteria that we talk? If we go one of them, one by one, only the leader-free 2 trial is covering all of that. And the master DAPT is covering most of them. And still, we are waiting for the result. Now, in that definition of high bleeding risk, they said, the definition of high bleeding risk that if there is a risk of bleeding exceed 4% per year. But look at those studies. The leaders, the 2 ones, they have bleeding risk higher than 4, except for the senior. So even with that, this study, they're still getting increased bleeding risk, even with testing this new method like shorter DAPT, new stent, and then. So still a lot of work needs to be done for the high bleeding risk. And this is some of the studies using kind of stent, whether from Terumo, the Ultimaster, you know that. I'm not going to describe all those kind of studies, but there's a lot of study. And the improvement that's going on now remember, I changed now the color of my slide. We are getting now more information, clear information. Before that, it was not clear information. So intravascular imaging, advanced stent technology, that the stent is getting less thrombogenic and the polymer is thrombogenic resistant. We are getting potent antiplatelet agent and improved secondary prevention. We are using a lot of statin, a lot of more PCSK9 inhibitor. So, and this is the difference between the first generation and the second generation. Look at the intima, how's the difference between the 2 stents. So we still need to keep balance between bleeding risk and ischemia. So everybody thought that let's try to get of the some antiplatelets, since we have potent antiplatelet like ticagrelor. So we are moving in this direction, and it is a little bit cloudy here. But we get the more cloud because of a new potent P2Y12 inhibitor. We got unanswered question from the Plato. The Plato now is more than 10 years old study and telling us that the people in the US, the patients were randomized in the USA did not get significant benefit compared to the people in Europe. And they told us from the Plato also, use lower dose of aspirin, you'll get better result. If you use higher dose, you'll get more bad result. What's the reason for that? We don't know. Another cloud came that from the Global Reader study. The Global Reader study is done in Europe and comparing two single DAPT of ticagrelor after 1 month of dual platelet for 1 month dual platelet, then single DAPT ticagrelor for 2 years, and comparing to all the other, and they just missed the p-value. The p-value is 0.07. And but a lot of criticism because of lack of education of the mortality, and a lot of comparators arms compared to the testing arm. So there is not an answer from this. Another cloud came, increased focus on bleeding and concern about antiplatelet stacking that I talked about, and also fear of aspirin-related bleeding complication, especially during the year of 2019. Remember, three study told us that the aspirin doesn't work as a primary prevention medication. 3 study came. So a lot of cloud, that means there is a perfect storm for another light to come, and that's why came the Twilight study. The Twilight study used that single arm of ticagrelor with placebo compared to dual DAP after, remember, after 3 months of door plan. But this was really educated, really well done study, well educated, and they really worked on the efficacy. They kept doing what we call pill counting. For every patient, they used to count his pill, whether he's taking medication or not, to assess the efficacy. And with that, we got significant reduction in bleeding with no harm at all in affecting the ischemic events. So this is the summary of the the Twilight, and the Tycho for the acute coronary syndrome showed the similar thing that this is done in Korea and Japan. And yesterday, our chairman did mention about the Tycho's STEMI, and this is the Tycho STEMI, and I was able to bring that slide that there is a significant reduction in net adverse clinical event, whether intention to treat or as per protocol, without affecting the risk of ischemia. So this is even with STEMI patient that we are giving 1 month of DAP and without increase of bleeding, but keeping in mind we are using now the new generation of the stent. Now we have to mention also about the Science DAP. The Science DAP has 2 arms, comparing whether giving DAP for only 28 days or 90 days. It's just for 1 month or 3 months, and there is no comparison arm. The comparison arm will be historical background, and this is again, look at the result. For Science 90, the same incidence of events, and this was non-inferior, definitely non-inferior. So we can use now the 90 days with Science without any problem. And this is the Science 28 days, the same, no difference, and this is non-inferior again. Now for the effect of the bleeding, just remember, this is the p-value is 0.6. So whether that's superior or not, but just remember, as I told you, what's the comparator arm? The comparator arm is the Science study, which was done 5 or 10 years ago. And at that time, there were no definition of BARC2, only BARC3. So that's explained the difference. So if we take BARC2 again out, this is superiority. Here we have superiority. So, and the rate of stent thrombosis, really, I can't believe that. Look at that, stent thrombosis of 0.2%, whether you give that for 28 or for. So this is now prolonged DAP only for the patient with who is low bleeding risk and high ischemic risk. And if there is low ischemic risk and high bleeding risk, there's only short DAP. Low ischemic risk and low bleeding risk maybe use short DAP, but we need more data. And the high ischemic risk and high bleeding risk, mainly short DAP with ticagrelor therapy. And other things, just remember to do it in the cath lab. Do transradial, prevent acute kidney injury, minimize the number and the length of the stent by doing FFR guided strategy like the famous study, provisional stenting for bifurcation, and special attention to under deployment, and use imaging to make sure the result is good. Now, I'm done, but just we cannot, I did give you only options. But if we need a trial to explain the high bleeding risk, just we need to choose the upstream pharmacology, cath lab pharmacology, post-procedure pharmacology, patient-related factors, and procedure-related factors. So let's discuss quickly that. So upstream pharmacology, whether we need to do aspirin upstream, high, low dose, antithrombin, whether unfractionated bivalirudin or not, GB23 inhibitor like eptifibatide, agrestat, and in the lab we give aspirin, antithrombin. With that you get 20,000, this is 20,736 options. This is only in the lab. And now, if you take the patient, can you compare this patient to this patient? This is Arnold Schwarzenegger, and this is Arlene. How different their muscles, how different their weight. And look at that. How many criteria we can differ from one patient to patient with age, weight, creatinine clearance, smoking, and all of that will get 2,096 option. And then in the CAS lab consideration, whether we are using a strategy of early invasive, delayed invasive technique, femoral, radial, bifurcation, and that will give us about 2,500 options. So if we calculate all of that, we'll get a number called quintillion that. Until this exceed the number of the people on this globe, until someone showed me this trial with this number that cover all of that, we can make a decision. Otherwise, it's a decision of the doctor who has to sit with the patient, look at all this factor, and then, so there is still position for the doctor. I don't think any what's happening with telemedicine, artificial intelligence will take the position of the doctor, no, because they cannot do this trial. With that, I think I stop home. Thank you very much.